So thank you very much for the introduction and for the invitation. For 20 minutes, that is a really daunting task to cover all what I was asked to cover. I have some disclosures, but mainly on performing studies over the many years. So the biggest caveat, I'm not a pharmacologist, so don't put me or burn me to the stake on the pharmacology, because that's not my field. I'm a hematologist, meaning that I will do a lot of the discussions using the stem cell transplant patient as the model, a little bit on solid organ transplants because there are similarities and there are differences. Of course, numerically, the biggest CMV problem is congenital CMV. And that's something completely different, and I'm not going to go into that at all. So I'm going to spend some time on the new antivirals, a little bit on vaccines, and of course, as the previous speaker talked about, the immune system is very important when we talk about CMV. CMV is a large and complex virus, and there are many different targets for antiviral drugs, although only a few have been really addressed by new drugs. But depending a little bit on the mechanism of action on the different antiviral drugs, you can expect slightly different outcomes. A lot of what has been discussed already was on Ganciclovir, and that of course goes to UL97. But in the end, it's the DNA polymerase that is the most important enzyme to address, the UL54. And then Letermovir has a completely different mechanism of action. There are three concepts in the immunocompromised host population. It's prophylaxis. You start a drug before you see any viral replication. It doesn't mean that there is no viral replication going on. It just means that you don't find it, okay? Because you probably don't look in the right place. If you look in urine, you will find something different than if you look in blood. If you look in blood, you will find something different than if you look in saliva. But we are using blood as our model. We have the terminology preemptive therapy that was coined in CMV management, and that means that you start an antiviral therapy before there is any signs of disease in the patient. And finally, you have the treatment of established disease. And there is a nice correlation to viral load. And today, with quantitative PCR technology, you really can have this cut off a little bit where we are. But the individuals vary. So what is the cutoff for disease in one patient will not be the same in another patient or another immunological situation. So what's the CMV therapeutic landscape? Well, it's already in the title of my talk: antivirals, antibodies, T cells, and vaccines. And I will spend some time on all of these. And none of them exist in a vacuum. They are existing together with the patient's immune system, if you talk about immunocompromised patients. Both the intrinsic immune defect, but also what we do to the patient, namely the external immunosuppression through drugs. These are just 3 slides saying that there are many options that have been used over the years. This summarizes about 35 to 40 years of management of CMV with prophylaxis. We've heard about Ganciclovir prophylaxis by the previous speaker. It's been around for a long time. And I also here said, where do we have good data to really support what we are talking about? And for prophylaxis, we have had some spectacular failures. Maribavir, which I'm going to talk about, failed miserably as prophylaxis, probably because of a completely wrongly chosen dose. Brincidofovir orally failed as well because of significant toxicity. But then, of course, we have the success story of Letermovir. These are a similar slide on the preemptive therapy options. We have, generally speaking, better data on preemptive therapy because it's been the mainstay of our strategy since at least 20 plus years by now. And then finally, therapy of disease, which in the stem cell transplant population is a failure of strategy. The patient should not develop organ invasive disease because then we have failed to prevent it. And our aim is absolutely to prevent. But here are the therapeutic options for treatment. So starting then with the two new kids on the block, Letermovir is introduced now since about little less than 10 years. It's completely human CMV specific. If you look back in the literature, there's a lot of models with mouse CMV and rat CMV and guinea pig CMV, but Letermovir doesn't work on anything but human CMV and not on any other human herpes virus either. Not simplex, not zoster, not EBV, whatever you name it. It is a terminase inhibitor, so it's very late in the replication cycle, meaning that there is some DNA synthesis going on early on in the virus replication cycle, and the sensitive PCRs can detect that DNA synthesis when cells lyse, and that is not necessarily a failure of the drug. There's no cross-resistance to other antivirals, which of course is nice. It's approved now in the EU for adults and children. It's available both oral and IV, and it has actually a quite mild toxicity profile, a little bit GI, and I will get back to interactions. Here are for you as pharmacologists and pharmacists, this is of course the bread and butter, where does this drug work on various enzymes. The most important is the effect on the PGP that has an effect on cyclosporin concentrations. So this is what we are dealing with. We are dealing with that the Letermovir increases the exposure of cyclosporin, tacrolimus, and sirolimus, but not on MMF. And you have to dose adjust if you give it with cyclosporin. You half the dose of the Letermovir if the patient is on cyclosporin. There is some effect on voriconazole and isavuconazole, but nothing on posaconazole. And this is the pivotal study as published in New England Journal by the now unfortunately deceased Dr. Marty from Boston, clearly showing that there was a good effect in preventing CMV reactivation, defined as clinically significant CMV infection, not only during the time it was given, which was 14 weeks, but for another 10 weeks as well, out to 6 months after transplant. And it also, to everybody's surprise, including myself, who has been involved in Letermovir for many, many years, it resulted in a decreased all-cause mortality. And that's unheard of when we talk about an infection, either prevention or treatment. This has then been studied in hundreds of real life studies, and this is a systematic review and meta-analysis coming a couple of years ago, showing that it not only affects on clinically significant CMV, but on all CMV reactivation, on CMV disease, and the effect on mortality and non-relapse mortality and hospitalization. You know, it's a wonder drug. It actually has revolutionized our dealing with CMV in the stem cell transplant field. But of course, all the sun has the spots, and when you stop, and if the immune system is heavily immunosuppressed, so you have the high-risk patients, you see reactivations, but reactivations occur later, and that is in general beneficial to a stem cell transplant patient to postpone the problem a few months. But to see if you could do something better, there was a randomized trial comparing 100 days of Letermovir to 200 days of Letermovir. More is better, right? And if you look to the left, it looks that way because it was, as you can see, a very strongly significant difference in the time to reactivation in the 200-day group. But then you stopped, and then you get the slide to the right, and CMV hit back. And when you come out to a year, there is no difference any longer. And this is the high-risk group. Okay, so therefore we cannot say what the optimal duration of prophylaxis is. Most patients don't need extended prophylaxis. The 100 days, that's fine. But you have extreme high-risk patients with very poor immunoreconstitution, and then you might need to give it for a year or maybe longer. The good thing is that there was no increased toxicity in the 200-day arm versus the 100-day arm. So it doesn't seem to be a problem with extending the duration. It is a bit toxic for your budget, but that's a separate story. So what we do, we have an individual assessment. We look at the 100 days. What does it look like? Okay. Yeah, then we stop. If the problem, the patient is still heavily immunosuppressed, graft-versus-host disease, no T cells, we give it for another month, and then we check again, and we give it for another month, so we don't give a fixed duration. We individualize our prophylaxis. It was also approved for kidney transplants in the donor positive, recipient negative, and this is the pivotal study showing no difference to valganciclovir, but if you look at the curve to the bottom right, there is a big difference in neutropenia, which was what was described by the previous speaker as the main toxicity of ganciclovir. Clinical efficacy the same, but less toxic. So who should then get or not get Letermovir? Well, it is seropositive patients. It's not approved for a positive donor into negative recipient in the stem cell transplant situation. It's not indicated for any CMV seronegative patient. There's currently no indication in any other solid organ group than in the kidneys. And it should not be used for antiviral therapy because of the risk for resistance. Then we have the other new drug, that is Maribavir, which actually is not that new. I heard about it 15, 20 years ago when it came out in the HIV population, and it looked interesting from the beginning. It works on the UL97 like ganciclovir, but with a different mechanism. It doesn't pass the blood-brain barrier, which of course is important. It's improved in the EU for adults, in the US from 12 years. It's only an oral drug. Again, a nice toxicity profile, a little GI, taste disturbance, but nothing significant in renal, bone marrow, or liver toxicity. But it is like, it has a resistance problem. This is the pharmacological effect of Maribavir. A little bit similar, but I would say milder as a interaction drug than Letermovir. Again, cyclosporin, tacrolimus, and sirolimus, but we do therapeutic drug monitoring on those anyhow, right? Not a big issue. And this is the pivotal study. And the pivotal study is on 4 times the dose for therapy of resistant refractory CMV compared to the failed prophylaxis study. And it is compared to its investigator-assigned therapy. So it was an open-label randomized study. And as you can see, 2 things from this slide. It's more efficient than the alternative, but you give it for 8 weeks, but when you stop, quite a lot of patients relapse in the CMV again. This is the side effect profile. It's much better than foscarnet when we talk about kidney toxicity, much better than ganciclovir when we talk about bone marrow toxicity. No bother about that. It's a very nice drug from a side effect profile. But here is the big problem with Maribavir, and this is the pivotal study looking at resistance. And at baseline, there was a rate of 1.7% resistant strain. At 8 weeks, or that Maribavir was discontinued, it was 25% resistance. And in those who don't respond, 48% had resistance. And in those who responded temporarily and then rebounded in viral load, it's 86% resistance. So it is a drug that has to be used with some care. It has been used in frontline preemptive therapy. It is against valganciclovir. Both drugs should be given for 8 weeks, which is a bit strange design because we never give ganciclovir or valganciclovir for 8 weeks. And it was designed as a non-inferiority study, and it failed. It was inferior to ganciclovir on efficacy. Partly because of resistance. It was much more resistance, but not as high in the therapy. And it gave less bone marrow toxicity as expected. But 56 days of valganciclovir for preemptive therapy, our median when we use it is about 20 days. So it's very long therapy. So this was a strange study. I represent the European Society for Blood and Marrow Transplantation. We have our office just across from the Leiden Medical Center. I was there earlier today. And this is our clinical experience in the EBMT in a retrospective study on Maribavir. So these are the patients. It was presented at the European Hematology Association earlier this year. And these are the indications for Maribavir use. And this is the summary. 71% had a successful treatment. So, it works, but it has, as I said, you have to use it with care. And the reason was stopping, you see below, a little bit of response on rebound and some other issues. Pediatric use, Letermovir is approved down in the EU from 5 kilograms in the stem cell transplant population. And I think it's 6 kilograms in the US. And Maribavir is approved from 12 years in the US and not in pediatrics in Europe. Then a few words in the end on other things. Immunoglobulin is, of course, a big discussion. It's the most expensive, most poorly studied drug in my experience in hematology. But here we have standard versus hyperimmune. There have been absolutely no controlled trials over all these years. There are case reports, small case series, mainly retrospective. And the problem is that it's used in a sort of desperate situation in SOT. So it's a tricky one, but the data supporting hyperimmune globulin versus immune globulin is extremely poor in my opinion. There was some interest in monoclonals about 2 decades ago. Nothing has happened for the last decade at least. And then we have the vaccine story, which has been waxing and waning over many years. And there's been many tries to design CMV vaccines. So far, nothing is licensed. The town vaccine was a live vaccine. It was used in solid organ transplants many years ago. Was not developed to registration. The GB vaccine, the same. The DNA vaccine as prophylaxis, the same. We have now 2 vaccines, what's called the triplex vaccine being studied now in liver transplant patients, and the mRNA vaccine, which is being studied in healthy young women to see if we can prevent a congenital CMV and a little bit in stem cell transplants. We can think about some situations where these vaccines could be used, and this is the stem cell transplant situation. I'm in favor of the second one, we give Letermovir as long as we need, and then we try to prevent that late reactivation with the vaccine. That would be a very nice study to do and to see if that works. There is also some work in vaccinating stem cell donors, which is another interesting possibility for that vaccine. In the solid organ transplant patients, it is the positive donor into negative recipient, that's the risk. And here you should vaccinate the candidates who are CMV seronegative. And that study is being done with a triplex vaccine in liver transplant patients in the US. And then, of course, we have the immune system. We can use virus-specific T cells. They work, okay? There's no doubt about it. There are many studies showing that they work. The problem is access. How do you get these T cells? Is it from the donors? Is it from third party? And that has not been worked out, despite I sat beside a pioneer in this field when I worked as a postdoc in the US in 1986, 1987, and we still don't have it all over the place. So it's been difficult. But this is a summary. Very nice paper came out a few months ago looking at efficacy of T cells, and generally it works. But it works the best in situations where also the antivirals work. So it's, again, something that needs to be thought about. So what's next? Well, we need to fine-tune the Letermovir. IV brincidofovir is being developed just now for adenovirus infections. That might become an option. Can we give combination therapy? That's an interesting discussion. There's just now being some work done in the US. We start with foscarnet in patients, solid organ transplant patients with high viral load, and then add Maribavir, for example, to prevent the resistance development. And will we have a vaccine? Well, that is in the future. So I quote the Danish philosopher that problems worthy of attack prove their worth by hitting back, and that's absolutely true for CMV. Thank you.